So honored to be here today. Thank you for your attention. I'm going to talk about transitions of care off treatment, and it allows me to talk about two areas I'm really passionate about, and that is what happens immediately off active treatment, and then what happens down the road when we're thinking about transition to adult follow-up care. And there's certainly other transitions along the way. So there may be transitions to other providers, whether it be a different oncologist providing survivorship care, a transition to primary care, to other specialists. So I will address those a little bit, but like I said, I will focus on that immediate transition off treatment and to follow-up care. So first I'll talk about transition off active treatment. And I will say that this is not a rich area of research. Thanks to Claire Wakefield and her work in Australia, she's done some reviews on the research that does exist for this transition off treatment, but we still don't know a lot. What she found, to summarize the negative and positive outcomes, is that it's a mixed bag. So for the children after treatment, what you see are some lower psychological well-being, reduced physical functioning, sleep problems, behavior problems, social difficulties and isolation, as we just heard, reduced self-esteem, and certainly lower athletic competence. On the flip side, there are also some positive outcomes. So for these kids, many of them have more positive behavior, as Bob just alluded to, higher self-worth, in some instances less risky behaviors, and improved social emotional roles. When she also reviewed the qualitative data, and as you'd expect, it's really complex and mixed. And what she said was there's really this joy and relief coupled with exhaustion, adjustment difficulties, and concerns about cancer recurrence and what next. And I inserted a quote from a patient of mine that when she said this, I said, okay, I just want to record exactly what you're saying, because I think you speak for a lot of patients coming off treatment. This is a 13-year-old, very smart, precocious girl with a solid tumor coming off treatment. And she said, I know I'm supposed to be happy, but I am not. How do I know there isn't a cancer cell floating around? I still have pain in my back and legs and have to go to physical therapy all the time. I can't keep up with my friends and feel so out of the loop. I'm way behind in school and I feel exhausted after a few periods. Seriously, this sucks. So Claire Wakefield also did a systematic review of parent adjustment, and again spoke to the duality of the experience of both positive and negative emotions. Certainly there's a really large focus on fear of relapse and cancer worry, also anxiety, post-traumatic stress, again, that physical and emotional exhaustion. And what she found in the summary of the data is that this improves over time, but certainly you see blips around the time of coming back for follow-up care for cancer screening. She also noted that this intense worry about cancer, fear of cancer recurrence and worry, is that she noted we really don't have an idea what patients and their parents' actual perception of risk is. And, you know, I see long-term survivors in survivorship clinic at CHOP, and it is astonishing how many of them live with this intense fear that their cancer will come back even if they're 10 years off treatment. And sometimes that is a very powerful intervention in and of itself, is to say, to realize you're really worried about this and to bring in the medical team and to sit them down and say, your cancer is not coming back, or your child's cancer is not coming back. There are two studies that also focus just immediately within 12 months after treatment. So the reviews I just cited were a range of studies within about 5 years after treatment. And what these two studies found, again, is that fear of relapse. There's also parent concern about interpreting physical symptoms. So just this idea of like, I don't know what to worry about anymore. What's normal, and what am I worried? When should I be worried that cancer's coming back or that there's something seriously wrong? They also Noted that they want to be connected to the oncologist still, uncertainty about timing of survivorship information, insufficient information, and concern that it wasn't tailored to their child's treatment, need for more preparation at the treatment completion, and also information about infertility and late effects. And the summary of some of the suggestions from these studies is that off-therapy education should include problems of daily management, information on diagnosis and ongoing precautions, plan for off-therapy care and emotional support, help dealing with anxiety, and they also wanted easily accessible information, so booklets and online web support, and support groups were the least favored modes of intervention. So although that's some lovely data and it's hypothesis generating, we really don't have a good idea from rigorous research about what's happening in this time period off treatment. There's lots of limitations, including small sample sizes, unvalidated measures, lack of control groups, and really a lack of definition of this part of the cancer trajectory. So what do we call this care off treatment? Is it follow-up care? Is it just off treatment care? When does it become survivorship care? So before I move on to long-term transition to adult follow-up care, I just want to summarize really what the research should focus on in this area more recently off treatment patients is to identify the demographic, disease, and treatment profiles that confer risk and resiliency post-treatment. We need to understand who's really going to adjust well after treatment and who do we need to continue to provide more intensive services to. We need to also have a better understanding of providers, patients, and parents' perspectives of care and concerns at end of treatment. Certainly develop interventions after treatment, and better define this cohort and best practices for care. So what qualifies somebody as recently off treatment versus a long-term survivor? What is follow-up care versus survivorship care? And when does survivorship care start? And also, who stays engaged in follow-up care? So there's a lot of studies, especially from the CCSS, that have described healthcare utilization for long-term survivors, and even some studies looking at predictors of attendance at follow-up care. But we really don't know much about the trajectory of attendance or engagement in follow-up care immediately off treatment. We did a study at CHOP that identified some predictors of follow-up care in the 5 years after treatment and identified demographic, disease, and treatment-related variables that predicted care, but there's really not a lot of research on this. So moving on to more long-term transitions, I'm going to talk about transition to survivorship and adult follow-up care. And I group these together purposely because we don't really have a good definition for separating out those terms of survivorship care and then thinking about care in the adult healthcare system. So these transitions may be obvious or they may be vague. Even sometimes the patients, when they come to our survivorship clinic and they've been transferred from their primary treating oncologist, they don't have a good sense of what the different care models are, why they've been transferred, and what the purpose is of moving away from their primary treating oncologist. So I note that this notion of survivorship care is often confounded with care for adult cancer survivors of childhood cancer. So we know that this is a huge issue. Again, I mentioned the CCSS has looked at this, and less than 30% of adult survivors are receiving cancer-focused follow-up care. But what about younger survivors closer to end of treatment? When does their care become survivorship care, and what is their trajectory of engagement, as I mentioned earlier? So in terms of survivorship models of care, I'm summarizing a little bit of the research and literature here that's noted models of care and the pros and cons. So you can continue survivorship care in a cancer center. And there's certainly pros related to continuity of care, the ability to facilitate training and research, and the expertise of the team that knows you. The cons are that it's resource intense. There's also a disconnect from primary care, and as patients grow up and certainly become adults, you want them to be engaged in health promotion and primary care. There's also the geographic distance issue of continuing to come back to a cancer center. Now, if you think of the survivorship care happening in the community with the general practitioner, the pros are it's cost effective, more easily accessible, more real world. There's the potential to integrate survivorship and primary care in the same visit, a focus on wellness and support and a model that supports independence. And then there's potential cons as well. So there may be less continuity of care from the original oncology team to primary care, less focus on cancer history and education, less comprehensive risk-based care, less amenable to research, less time potentially, and less psychosocial support potentially. And if you put these together, you get a shared care model. And this would be, there's follow-up with oncology with coordinated transition to community-based care and potential ongoing contact and consultation from the cancer center or the oncologist. So we don't know really much about best practices. We can hypothesize that there's pros and cons of these, and there may not be a one-size-fits-all model, but we really need more research on this area. The recommendations out there talk about that transition must be well organized and coordinated. We must have a treatment summary and survivorship plan for these patients. Education needs to be provided to patients, parents, and providers on this survivorship care and needs. We need to have up-to-date guidelines. People have mentioned the COG guidelines. And there needs to be a focus on readiness for transition so that the patients work to become more autonomous in their care and can engage in long-term follow-up care. So I'm going to shift gears and talk a little bit about my program of research on transition. And if any of you know the general transition literature, traditionally it's focused, and I say general transition, I'm talking transition to adult care for any pediatric chronic illness patient. There's really a lack of rigor in this area, and traditionally the research has focused on acquisition of disease knowledge and skills. And I've always argued that that's not the best, that's not the most comprehensive way to approach transition readiness, and especially in oncology, you know, where there's such an emotional and traumatic history for these patients and families and such a bond with the pediatric cancer center that there's a lot more complicating factors involved to get them ready to make that transfer to the adult healthcare system. So in my program of research, we've developed a model of transition readiness that's more comprehensive, and we're also working on developing a measure of transition readiness. And we're following pretty rigorous measurement development methods guided by PROMIS, the NIH's Patient-Reported Outcomes Measurement Information System. So I think of transition readiness as a process over time. So you take perhaps a young adolescent, they're off treatment, and you want to start to get them ready for transition readiness. And this includes a whole lot of aspects, disease self-management, knowledge, motivation to engage in healthcare. And the idea is to assess this over time and use that assessment to identify targets of intervention to get them ready for a transfer of care. And a successful transfer of care at minimum would be engagement in an adult healthcare setting. So we developed SMART, this model of readiness for transition. And what you see at the top is what pre-existing factors. So you think about what are the sociodemographics and culture of the family, access and insurance, medical status and risk, and neurocognition and IQ. And those pieces will all influence what we call the more modifiable variables. And that is the disease knowledge, skill self-efficacy, beliefs and expectations, the goals, relationships, psychosocial and emotions piece, and the patient developmental maturity. And aside from the developmental maturity, all those variables in the middle, we hypothesize relate to patients, parents, and providers. So this is not a patient-focused model. This is really engaging the whole system on the pediatric care side. Okay. So we did some work to validate the SMART model. Did a mixed method study. And I'll just point out a few of the results. When we asked patients, parents, and providers of long-term survivors to rate the components of SMART that they think are most important for transition readiness, you can see across the board there's unanimous endorsement that these are all important. So people really embrace this social ecological model of transition readiness. When you ask them to say what's most important to me or most important for my child's readiness or my patient's readiness, you see some discrepancies. So one thing that is interesting, if you look at the right, the green bar of providers, the component that the providers most often endorsed as most important was relationships. And in the qualitative data, they really reported that what we all anecdotally know, and that is it's hard to let go. And that was just, I mean, people were very blatant about it in the interviews. Parents also feel that. So if you look at the relationship, the red bar for the parents was also high. And then for the patients, what was the most difficult or the most important was access and insurance. So for them, it was more logistical. It was like, okay, I'll move on, but I have no idea about this. Like, where do I go? What's in my insurance? Like, how do I make this happen? And what's not that high relative to some of the other ones is knowledge and skills. So again, this is supporting the idea that there's a lot of components involved, and there's also discrepant views of what's most important between patients, parents, and providers. So we also did a study, and we will submit this data soon. This is with one of the top fellows in the room, Dava Zalda, where we looked at what happens after transfer. And I want to highlight again that there's a lot of data out there looking at healthcare utilization of young adult survivors, and Dr. Effringer will certainly talk more about the care provided to young adult survivors. But there really hasn't been a study looking at, okay, if we know we try to do a really good handoff and we transfer these patients to an adult provider, we told them this is where you're going to go for your follow-up care, what happens? So we looked at patients within 5 years after transfer, and we asked them what their healthcare utilization was like in the last year and if they had cancer-focused follow-up care. And we found that 55% did engage in adult-focused survivorship care, 50% from a primary care provider, and another 50% from a specialized practice or a shared care model. And those who did not seek cancer-related follow-up care did indeed have a visit with a primary care provider. So there is some healthcare utilization happening. They are engaging in the healthcare system, but again, about 45% of them aren't endorsing survivorship-focused follow-up care in the last year. And some preliminary analysis of predictors of follow-up care shows that, this was interesting, everybody who said that they did have a visit in the last year reported that their parent was the primary decision maker for their health. And I should say that I think the mean age of these patients was about 27. They reported high motivation for follow-up care, so they had some intrinsic motivation. They also had private insurance and low post-traumatic stress scores. So this really, again, further supporting that transition readiness is complex and patient motivation is key. So I want to shift back to early intervention and what happens in that time period immediately off treatment. And we've developed an mHealth pilot study, a small randomized control trial, where we are randomizing adolescents age 12 and up off treatment, within 1 year off treatment, to receive daily text messages or a survivor handbook. And those daily text messages are sending them messages about ways to stay healthy, general adolescent health promotion. There's also some more tailored information about things that they should be doing or not be doing based on their cancer treatment history. And we're also providing resources for them, and we're helping them, giving them tips on how to adjust back to school and social life. So they're receiving these daily texts for about 16 weeks. They also choose a goal, one of 6 goals that they get extra texts on. So we kind of target information, some of the text based on the particular goal that they're choosing. So you can see most of them are actually choosing to increase physical activity as a goal, or healthy eating. So they are indeed focused on health promotion and wanting information about that after treatment. So our intervention is called Thrive, Texting Health Resources to Inform, Motivate, and Engage. So our messages really fit into these 3 different buckets: to inform them, to motivate them with goals and encouragement, and to help keep them engaged. We actually also send them appointment reminders. So thus far, we've had 22 complete. Their third are minority. The mean age is 17. And just peeking at the data so far, we found that it's feasible and acceptable. The majority are reading the text, said the amount was just right. All of them said they would recommend it to others. You can see that the text messages groups endorse that as easy to make time, easy to use. And both the text messages and handbook groups said the information was easy to understand. And they're also endorsing that the text message group over the handbook group, that it had a positive impact on their physical health and quality of life. And I love that. This literally just came in over the weekend. I wish I could hang my hat on just this quote and deem this an efficacious intervention. But we got an email from one of the participants who finished up, and she said, "I actually really benefited from everything I learned. Thank you so much for the opportunity. I think more people should be concerned with what happens after cancer and be told what is good or bad to do, because when I finished treatment, I feel like I was just thrown back into the real world and felt really lost. But I feel this whole study has been really helpful to me, truly." So I'm going to wrap up as quickly as possible. To summarize, we know that patients and families are still struggling on that transition off treatment. There's potential opportunities to keep patients engaged, but also for them to be lost to follow-up over the trajectory of survivorship after treatment. There's also differing perspectives that need to be accounted for in transition readiness. AYA survivors are in need of intervention to improve that motivation as they get closer to the transition to follow-up care. Definitely there's more education needed of the patients, parents, and providers, including general practitioners. And I think we need to do a better job about giving patients and families treatment summary and tailored care plan. So specific research recommendations focus on research soon after treatment, because again, I think that's really a ripe area where we don't have rigorous research. We need to better understand the models of care, study patient, parent, providers' perspectives on best practices, and develop interventions to improve engagement and adjustment across the trajectory recently off treatment through long-term survivorship. And echoing what we talked a lot about today is we also need patient-reported outcomes that we can use across the trajectory of cancer and across development to monitor how they're doing long-term. Thank you.